Okay, sounds good. Welcome everyone. I'm going to go ahead and get started, and then Joe Prado's on to help share some of the updates that have come along related to vaccinations. But I'll go ahead and start with our metrics. So this is a dashboard that the state provides that shows where we are with our COVID hospitalizations. And as you can see, this number of 297 means that there's 297 patients in the hospitals at this time. So this basically shows you ever since like 2020, ever since 2020, what's been going on. Let me flip it to Fresno. And you can see this big hump is the winter surge that we had last winter. And then this little hump or smaller hump, it wasn't so small living through it, but that was the last fall surge that we just are hopefully getting out of. Now, what's really concerning is that these numbers are not really coming down all that much. And this is really something that other counties have also started to experience, even in the Bay Area, where their numbers came down much faster than ours did. And now at this point, sorry, we had an iPad emergency. All right. So basically, I think the point I was trying to make is that our hospitals remain impacted. And unfortunately, I don't see this getting much better. I think that for the next few weeks, we're going to be in the high 200s. And then that will basically set us up for what I think is going to be a pretty bad winter surge. I hope I'm wrong, but that's really how I'm looking at these numbers, to say that we've really kind of flattened out. We're not really coming down as nicely as we want. And so that's kind of where things have ended up. Same thing with our ICU numbers. That's kind of where things are. Here's a forecast of what's going on with the ICU numbers. And here you can see that the ICUs have about the mid 50s range. And that those numbers are basically flattening out and plateauing. All right, so that's really what the numbers are kind of showing us, is that we've sort of hit what I think is the doldrums, and it's really very sobering to look at, because I think, unless we get really aggressive with vaccinations and really aggressive with getting the flu shots out, that in the next few weeks, we're going to start to see an uptick even from this relatively high plateau that we're at right now. Let me share, this is basically just the overall case numbers. I don't know that it's that germane to our discussion today, other than to say that, there's areas of the state where the case rates are even higher than ours, like some of the smaller northern counties. And then obviously there's areas of the state that are doing just fantastic compared to us. And we're kind of in the middle, in the high 20s with our case rate per 100,000, which really means that we still have substantial spread. All right, those are the updates that I had for the metrics. I know that there's been a lot going on with the vaccinations. So some of the happy news there is that we're on the cusp of, I think as a country, approving vaccinations for 5 to 12-year-olds that are 5 to 11. And we know that the FDA, there's many different committees that kind of touch this issue. And one of the main committees at the FDA went ahead and approved for that age group yesterday, and that the CDC will be reviewing and approving that same set of data next week. And then we're hoping that in the next week or two, we will go ahead and get the go-ahead to finally start vaccinating children. I know that raises a lot of questions, and believe me, we've been working double time to really prepare for that day when children ages 5 to 11 will be ready to get vaccinated. They're going to get a smaller dose, and because they get a smaller dose, there's going to be like different vials and kind of a little bit different process for how to get them vaccinated. The interval should still be the same. It'll be 3 weeks for Pfizer and 4 weeks for Moderna whenever that happens. But the doses will likely be smaller each time. And so that will basically be happening in November is what everyone is anticipating. And if Joe is on, I think he can share more about the logistics of how to make this happen. The bottom line is we need all providers on deck, pediatricians, general practitioners, FQHCs, any clinics that are out there. It would be amazing to have some of our hospitals jump in and start doing this for families, for example, of their staff, just to offer vaccinations if you have that bandwidth. But we're really going to need all hands on deck because this is a huge number of kids in our county that we need to get vaccinated very quickly. And obviously that will help everyone because that will be taking away a large pool of potential vectors going into this winter surge. So with that, I see Joe popped on the camera. So please go ahead with your vaccine update, Joe, and let us know what you've been working on.
Yeah, thank you, Dr. Vohra. So let's get you caught up real quick, team, on what does the total population look like as far as with at least one dose. We're at 56% has received one dose. 68% of our eligible population has been vaccinated with one dose. What we've seen in doses this past week is we've stabilized at 2,000 doses at this time, which at 2,000 doses per day for the entire Fresno County system, that means we don't increase percentages like less than 1% a week. So it is a very slow moving vaccine uptake that we're seeing right now. But we do see, and just for fully vaccinated, 46% of our total population, 56% is fully vaccinated of our eligible population. Moving into our younger population, 12 to 17, 49% have received one dose, and 43% are fully vaccinated in the 12 to 17 population. And so what we are seeing with the 5 to 11 here potentially being approved this week officially, not only through the feds, but through the state, we want to make sure that children are vaccinated like they normally are for other childhood vaccines by their pediatricians, by their family care physician, how they normally obtain their vaccine. And right now, we need to improve the system. We only have 15 pediatricians who are signed up to do COVID vaccine. All of our federally qualified health centers are signed up, but we need more individuals to come on. So you'll see a health advisory that we've submitted in this past, earlier this week that really gives every medical provider a framework on how, if you're not a COVID vaccine provider, how you can become a COVID vaccine provider and the current storage requirements for the Pfizer vaccine. The state of California has a program that expires early December, that if you sign on to be a COVID vaccine provider now, you would get $10,000 of one-time incentive funding to sign on to be a COVID vaccine provider. If you previously signed on to be a COVID vaccine provider, you can still receive those dollars. In our health advisory, it gives you the link that you would need to go through to sign up for those dollars. If you are a medical group, it actually will give up to $55,000 total for multiple sites as well if you are a medical group. So it's the state really trying to incentivize medical providers to actually sign up to be a COVID vaccine provider. And also we are in full support of it. We want our children to be vaccinated by their normal pediatricians. And so you'll see that. In addition to that, Fresno County, we also have medical grade refrigerators available. So if that is a reason why you aren't comfortable in stepping into the COVID vaccine provider realm, please communicate with us. We want to be able to mitigate that issue there as well. So we definitely have that refrigerator. So if you're a vaccine for children's provider, you're going to be communicated by the state of California and also by our health department. All VFC, CHDP providers, we want you here ready to vaccinate your children. You serve the vulnerable population here in Fresno County. So we definitely want you on. So you're more than likely going to see correspondence from the state and also from the local health plans. We're asking the local health plans to reach out to our providers as well. So you may start to see a big push and our physicians providing services to our pediatric population to sign up to be COVID vaccine providers. And so please consider that. Please sign up. We want to be able to do this through this format and be ready for to administer COVID vaccine by this weekend to our pediatric population. But really, we want to have as many doors and access available for our 5 to 11 age group as soon as we're able to receive those doses. As of right now, as of last week, when I looked at it, we had about 17,000 doses available of Pfizer pediatric doses available for us to order. Of course, we didn't order, the system hasn't ordered all those doses. We're going to wait to see what the demand's going to look like. But don't think that, oh, there's a supply issue. There is no supply issue at this time. We're really going to need to see, hopefully the demand will be there to draw down those pediatric doses. So Dr. Vohra, that's the main piece I wanted to kind of talk with the group today, and available for any questions.
Joe, do we anticipate that like the My Turn site will allow people to enroll their kids to get vaccinated? So that will all be kind of like a seamless expansion of what's going on now?
Yeah, seamless is the operative word, right? So what we saw last time, because things happen very fast, once it gets approved through the California, the Western states, it usually takes 24 to 48 hours for My Turn to be updated. So you're not going to be able to do it through My Turn per se, but if you walk into any of our vaccine providers that have the 5 to 11 formulation, you could definitely get vaccinated. Our team will do our best to see who is signing up for that and update that on our website. But we really want anybody who is managing Pfizer COVID vaccine, if you're comfortable in administering to a 5 to 11 age group, we want you to sign up for that formulation.
Okay, great. Any questions for Joe? Thank you for that great update, Joe. And thank you for all that you're doing with the VAX team to get us prepared. Let's hear your questions about this vaccine process and any other news or tidbits anybody has to share that we didn't cover that would be worth sharing.
Can hospitals have that incentive also?
Yeah, I didn't see any exclusion for the hospitals with that. So if hospitals previously signed up, they just have to go through that process to receive those to receive that funding.
Yeah, and I put a link in the chat for that funding. The deadline is December 17th. They actually extended it, but don't wait that long because we're going to need you long before December. So please let us work with you and support you to get you to become a provider. Someone's asking, the grant says it's for groups under 200 providers. Is that still correct?
Yeah, I know they allow for multiple sites, but there is a site limitation of only 5. So if you're a provider that has 8 sites, you can only be reimbursed up to 5 sites.
Okay, gotcha. Okay, great. Any more questions for Joe? All right, well, we will definitely talk more about this process as we learn more. This is a really exciting time, honestly. I mean, even though this damn virus keeps throwing us curveballs, I really feel like this is one of the final chapters in the pandemic, at least transitioning from a pandemic to an endemic, which is less disruptive of everyone's lives. And I think it's going to require us getting our kids protected. So I'm so glad that this is happening. I think a lot of parents all over are really glad to see these developments. All right, let's move forward, and I'm going to share my screen one more time, if that's okay, and just share just a few of the health messages, just because we've had so many health messages that we've been working on that I wanted to make sure that you're at least aware of where these are, where you can find them. So here's our health messages kind of dashboard. And then when you go down here, it just has health messages for medical providers. So as you can see, we have the one that Sim just shared in the chat, which is the vaccine provider enrollment. And then Sim, if you could share some of these other ones as I talk about them. So we just put out a health message related to RSV, another one related to reporting in daycares and preschools for COVID, and then one related to blood lead level testing. So it's actually Lead Poisoning Prevention Week this week. So I actually did a webinar with the state, the CDPH Lead Poisoning Prevention Branch on Tuesday. And so it's just something that, you know, especially if you're seeing pediatric populations, if you're serving some of our underserved and under-accessed communities, lead poisoning is actually kind of a big deal in Fresno County. We have a lot of different census tracts that have high lead levels and a history of high lead levels. So we do need to be vigilant about that. It's actually pretty easy to test, and it's actually really easy to treat because it's just been protocolized so much. But let me just walk you through some of these advisories. So the first advisory is about RSV. RSV affects some of our youngest and most fragile patients. So we just wanted to put out an advisory. This is very parallel to advisories that have been put out by the CDC, the American Academy of Pediatrics, and some of the larger counties like LA County. And it basically just warns people that, you know, we are now in RSV season. In fact, RSV kind of broke the rules and really broke out of its season. And we had really an uptick of RSV even during the summer months, which is really unusual. But you know, I think we can also expect that RSV might be bad this year, just because we kind of had a really good season last winter. And so there's a whole year of children where they just have not been exposed to RSV. And even though it's just a year in a toddler's life, that basically is a lifetime. And so, you know, because the seasonal disruptions that RSV has had, it's really concerning that we may have kind of a bad RSV season this season. One thing that people can do, which I didn't even know, is that there's actually a monoclonal antibody for RSV. So it's called palivizumab, and it prevents severe RSV illness in infants and young children. So it's actually a preventative antibody, and high-risk children should be receiving this. And really, basically, you're supposed to be giving it to your high-risk pediatric patients only during RSV season or the winter months. And this year, the American Academy of Pediatrics and the CDC said, you know what, just give it, just start giving it, you know, in the summertime. So just know that there is that monoclonal antibody. Hopefully, if you're a pediatric specialist, none of this is news to you. This is something that should be just kind of bread and butter pediatrics for those that treat RSV patients. But for those of us that don't see RSV every day, just know that it's out there, know that it needs to be treated, know that it needs to be diagnosed with testing, and just know some of the other resources where you can look up more information in case this is something that comes through on your radar. And if there are any pediatric specialists or infectious disease specialists that want to chime in and add to this very, very brief summary of RSV, then I won't at all be offended if you want to chime in and just add to those comments. Or drop them in the chat. This is another health advisory. It's for daycares. We just put that out there in case you have kids that are in daycare and then you wonder what the contact tracing is, you know what contact tracing is being done, whether you see those children as patients or they're just contacts or relatives of yours. Just know that, you know, we're basically reminding daycares that this is what they need to be doing for the purposes of reporting and contact tracing. And so that can be found on our website as well. And then just going back to this page, the blood lead level testing is something else that we were able to put out. So again, this is basically just a very protocolized process. And it's just something that, you know, all children that are coming from high-risk households or neighborhoods should get tested at 1 and 2 years old. And so, you know, children in programs that are in Medi-Cal, CHDP, Head Start, WIC, all of those kids, and really any other kids that you suspect as possibly having lead exposure should get tested at year 1 and year 2. And then you can do a capillary or venous blood lead level. Keep in mind that there are these lead check kits that you can actually buy at places like Home Depot if you're just trying to swab your surfaces for lead. And there may even be some over-the-counter human testing kits. And those are not as reliable as you can imagine. So it's really best to go through a certified laboratory and really just send someone to a lab because it's worth getting it done. I know a lot of pediatricians can do this in their own offices, et cetera. But just keep in mind that, the retail over-the-counter lead level checks are really not that great. And in fact, they basically have a lot of errors that the CDC is trying to message about. Beyond that, if you do have a lead level that's on the high side, then the CDC provides really good information about what to do. So call us, call me, call the Poison Control Center. This is bread and butter toxicology that Poison Control deals with all the time. But then also beyond treating just the patient, really look at the whole family and ask, how did the lead get there? Is the child eating something? Is the child eating chips of paint that are, from an old house where you get lead paint in an old house? Is the child exposed to dust that's kind of falling off the walls because they live in an older home, or is there some other occupational hazard that mom or dad is bringing home? So whenever you have a high lead level, you really have to look for the exposure. And that's even more important than actually chelating the child, is removing from exposure. That's like the number one thing that we always teach all of our residents whenever it comes to lead poisoning, is you have to remove the exposure. Sometimes that means the family has to go live at a hotel while we figure out what's going on with the house. But there's some good news there also, is that we basically have a big grant from, I think, the EPA that allows our environmental health division to go in and really remediate that house and fix everything up so that that child and the whole family is not exposed to lead anymore. And so that's something else that we can offer through our lead poisoning prevention program. So just keep that in mind, that, obviously check the patient, treat the patient, but then take a step back and really look at what's the source and how can we prevent this from happening to the rest of the family. And just know that there's actually a lot of grant funding available that goes unused, believe it or not, with home remediation and other projects that our environmental health division is ready to help with. This is one of those really cool projects and programs that's been so successful that you hardly ever hear about it. It's like, it's really one of the great victories of public health, is the amount of lead poisoning that we've been able to prevent. So let's keep it going. We have just, we still have a lot of vulnerable populations and affected populations here in Fresno, but there's no reason for this to be at all a challenge. It's so established after decades of science that there's nothing new under the sun when it comes to lead poisoning. It's just a matter of identifying those patients and families and getting them treated right away. All right, I think those are all of the updates that we had for the last few weeks. And so there's one last one that we had. Well, there's always the monoclonal antibody updates. This is Dr. Zweifler's perennial project. And the only update that we had to this is, even though this says September 24th, I think we're ready for another update to it, because we were just told, thanks to Sherry Backey, that Madera Community Hospital is also now offering monoclonal antibody treatments. So I hope that I represented you accurately there, Sherry. But thank you to you and the Madera County Hospital team for doing that. I think that is so awesome. Whenever you look at our monoclonal antibody treatments advisory, there's actually a whole list of all the different clinics that offer monoclonal antibody treatments. And that basically starts on page 5 and goes into page 6. And as you can see, there's a bunch of different clinics. We keep adding to this list. And now we're going to be able to put Madera Community Hospital to this list. If you are now doing monoclonal antibody treatments, and I certainly hope you're considering it, then please let us know so we can get you added to this list also. We want this to be a living document that really helps serve our community. You might have seen this story on CNN. It just ran earlier this week about how underutilized this medication is and how much it could really save so many people's lives, so many costs in healthcare. It could really help us put another dent into this pandemic, even for the unvaccinated population. Obviously, we want people to get vaccinated. There's no substitute for vaccination, but especially for those unvaccinated people that have the misfortune of coming down with COVID, then basically monoclonal antibodies can really keep that population out of the hospital as long as they get them early on, within the first few days of their diagnosis, or even before they get COVID, just while they're in that isolation period or quarantine period, just because they're a close contact. So please keep in mind monoclonal antibody treatments, but don't just keep it in mind. It's so easy to do. You should be doing them yourself. You can do them with an IV infusion, which is the preferred route. You can even do them subcutaneously if your patient is lower risk, meaning that they're vaccinated, for example, or otherwise look really well, but you still feel like you can give them monoclonal antibody treatments. Please look at this advisory. Dr. Zweifler did such an amazing job giving you everything you need to know about the science and benefits of monoclonal antibodies, the 3 different types that are available here in California, and then all of the details related to ordering, which still need to be done through the county Mohawk system. And we'll let you know whenever that changes, but right now we're still asking everyone to request through the Mohawk system. And if Dr. Z is on, I'll let you add to that if you have any more comments. Okay, let me share something else that's not COVID related. So let me just pause there and see if anybody has any COVID questions or discussion points that they want to share. All right. Kind of a quiet group today. I'm going to share something that's a little bit distressing, but I really feel like this needs to be something that our community needs to be aware of. And I don't have all the answers for this issue today, but it's just something that I want to put on your radar. It probably is on your radar, but it's really astounding to see what I'm about to show you. So with that huge buildup, let me just share this PowerPoint. So this is basically data from the American Association of Poison Control Centers. And my friend Ed Bote from the Iowa Poison Control Center, he's a medical director up in Iowa, but he basically pulls national data. So he's been looking at the national calls to poison control centers just throughout this pandemic. And he just shared this with the toxicology community. So just keep in mind that for the purposes of this slide set, there's a lot of disclaimers that the AAPCC makes us show whenever we show any of their data. But this is basically whenever you call poison control, all that data gets aggregated into a national database. And this is what I'm about to show you. So here on this slide, just keep in mind that the term ISS is going to get used a lot. And it basically means an intentional suspected suicidal exposure of someone that really tried to hurt themselves. So basically a call about a suicidal patient in a child or a teenager. And here's what the statistics show is that, here's what the US population has done in terms of the number of children and teens. It hasn't changed that much. That's what this slide is showing you is that, it hovers around 30 million just from 2000 all the way to 2020. Sometimes it goes up, sometimes it goes down, but the population has not changed. So that's number one. Number two, the number of exposures called to poison control hasn't changed that much either. It's usually about 2.19 million, 2.20 million. Sometimes it goes up to 2.6, sometimes it goes down. So the population of kids has not really changed in the last 20 years, and the number of calls to poison control have not changed in the last 20 years. Here's what's happened to all ages of that ISS category, which is intentional people trying to kill themselves. Okay, from 2000 all the way to 2020, there's been a gradual rise, which is very concerning, right? So this basically speaks to the larger mental health epidemic that I think all of us have lived throughout our adult lives. There's a little bit of a drop off because of COVID related disruptions perhaps, and also because 2021 and 2020, those data have not been crunched yet, and 2021 obviously is still going on. But really, it's just a slow, gentle rise with all ages. Now let me show you what's going on with teenagers. And this is why I want to share this with you because frankly, it's heartbreaking. So in the year 2000 to 2010, this was in the 40,000 range. And in the last 10 years, it's basically doubled. So the number of teenagers that get called, the cases that we're getting called about at poison control has basically gone from 46,000 to almost 90,000. And it's all girls. It's almost all girls, which is what this pink line shows you. I'm going to show you a couple more slides because we're going to get to another topic. But this basically just shows you, let's look at under teenagers. So this is like that, 6-year-old to 12-year-old group, the tweens. And basically these numbers have gone up too. Their absolute numbers are not that high. It's only, 1,700 versus 8,000. But golly geez, look at this. In the last 10 years, this number has also just gone up tremendously, especially in girls. Here's what happens with their admission rates. So again, everything just starts going up in the last 10 years. And then here, let me show you what the COVID pandemic has done. So this is what teenagers went through in the last couple of years. So there's 3 lines here, 2019, which is kind of the baseline. And Ed Bote, my buddy, who's kind of aggregated all these slides, actually has great explanations for all of these little points that you see, because they line up with things like spring break, Easter break, Thanksgiving break, Christmas break. So all of these little points really have to do with different kind of, holidays and times off during the school year. But overall, this is what 2019 looked like, the blue line. This is what 2020 looked like, which is the orange line. And then here's what 2021 looks like. It's a lot higher. Here's the 11 to 14-year-olds. Again, the red line is just a lot higher than the years past. And here's what it looks like with the gender breakdown. So again, that red line is a lot higher and it's almost all girls. So please, this is something that I think everyone is seeing different parts of. And obviously with poison control, we see just the people that happen to overdose on medications, and then someone calls the voluntary hotline of poison control to report that exposure and ask for help with management. So this definitely does not represent every single kid that's out there that's having mental health issues, but it is just another kind of red flag about what's going on with our young people. And the AAP and a couple of other agencies actually put out a declaration late last month just to say they've never seen the soaring rates of mental health that they're seeing now among children, adolescents, and their families. And again, like I said, I know it's really depressing data. I don't have any easy answers for this community, but it is something that I think we all should be aware of, so we can start to really have this conversation and look for solutions together. But the mental health, the pandemic has really just, sent all of these mental health issues soaring in so many different ways. And I think that we really need to be sensitive to that. And I can share, this slide set out if you're curious. Again, we're gonna be working with our behavioral health colleagues. I'm gonna be sharing this with our schools. And I'd really like to put together a work group on this from both behavioral health, public health, and our community to say, what do we need to be doing to help address this here in Fresno County? Because I'm just astounded by these statistics. Okay, let me stop there and see if anybody has any comments. And again, if you talk to your psychiatry colleagues, or if there's any of our psychiatry or mental health colleagues on the Zoom today, everyone's noticing this. So you're not alone. And I just hope that, if nothing else, please take care of yourselves and your families. And if you have young people in your lives, then just understand that this has been tremendously trying and challenging for them as well. All right, so I will share that slide set out in response to some of your requests. All right, let me switch gears here and introduce a featured expert because we have a monthly talk. As you know, in the last few months, we've done this every month. We have our emergency medicine residents that rotate with me on poison control, doing mini lectures about the different aspects of the health impacts of climate change. And today, it's my real pleasure to introduce Dr. Nikhil Ranadive. Nikki is a second-year emergency medicine resident with us at the UCSF Fresno emergency medicine program. But he's a published scholar in this topic. So I think that we're really in for a very good high-level lecture about climate change and its impact on the healthcare system. And with that, I'll let him share his screen. Thank you so much, Nikki, for putting this presentation together. I'm sure all of us will look forward to seeing what you have to present, and then hopefully having a discussion if there's time for that. Go ahead.
Thanks. Can you see my screen?
Yes.
Okay. And you can't see my notes, right? Just the presentation? Okay, perfect. All right, so today I'll be talking a little bit about climate change and healthcare, both with regard to the healthcare system and healthcare professionals. Please feel free to interrupt at any point in the presentation. I've got no disclosures. And before I talk about the objectives, I'm presenting this sort of with the understanding that some folks have seen presentations by my co-residents outlining the impacts of climate change on public health. I won't be covering that as much in this talk, but if y'all have any questions or want some of the gold standard resources for that, I'm happy to send those along. So the objectives for today are to discuss greenhouse gas contributions from the healthcare sector, to describe the impacts of climate change on healthcare systems, and then to examine mitigation and adaptation strategies within the healthcare sector. And so for that first objective, how much does the healthcare sector contribute to greenhouse gas emissions globally? And the answer for that is the take-home message for that is essentially a lot. So it's estimated that the healthcare sectors of the United States, Australia, England, and Canada emit a combined 748 million metric tons of carbon dioxide equivalents annually. And if the healthcare sectors of these countries were an independent nation, they would rank 7th in the world for greenhouse gas emissions. And globally, the carbon footprint of healthcare in 2016 represented an estimated 4 to 6% of all emissions. So the United States has the second highest per capita emissions, with healthcare estimated to continue upwards of 10% of carbon emissions, second only to Iceland. Another study in 2019 found that carbon dioxide emissions from healthcare in the world's largest economies accounted for about 5% of their national carbon footprints. The figure here shows the health carbon footprint as a percentage of national carbon footprint, grouped by region where that footprint is felt. So in the United States, that's almost 8% of the total carbon footprint coming from healthcare. In the United States, greenhouse gas emissions rose 6% from 2010 to 2018, reaching over 1,600 kilograms per capita in 2018, which was the highest rate among industrialized nations. And also in 2018, healthcare-related morbidity due to greenhouse gas emissions, in addition to healthcare-related particulate matter and ozone pollution, amounted to somewhere between over 200 and over 500,000 DALYs. So another question.
Can you just briefly explain what DALYs are? Because this
is I'm so sorry.
Technical epi term.
Oh, I'm sorry. So
it's
DALYs
like
they're disability adjusted life years. They're a similar metric to the QALY, but the DALY combines the years of life lost due to a certain illness or exposure, and also the years lost due to disability. So there are disability weights that are assigned by like the World Health Organization.
Right.
For various
and it's just a way to kind of level the playing field, because everyone thinks that their disease is the most important disease. And so this is a way for us to kind of compare apples to apples in terms of, this is what this actually does to people's livelihoods. And so that's why people came up with the term DALY. I'm probably not doing justice to it, but basically allows you to compare the impacts of different chronic illnesses. So that's, I didn't know that before doing more public health work, and I'm sure a lot of people had the same questions. So sorry to bother.
Oh, no worries. And so another question is, what are sources of carbon dioxide emissions in the healthcare system? So identifying and quantifying sources of carbon dioxide emissions, that is the carbon footprint of the healthcare system. It's complicated and requires defining system boundaries. And that encompasses the production and transport of medical supplies, patient and staff transportation, energy use in medical facilities, the investment portfolios of healthcare organizations, and more. And so hospitals are typically open 24 hours a day, 7 days a week, and contain several energy intensive activities, including sophisticated heating, cooling, and ventilation systems, computing, medical and laboratory equipment use, sterilization, refrigeration, laundry, and food service. The healthcare system also uses vast quantities of energy intensive goods and services, such as pharmaceuticals and medical devices. And these require significant energy inputs for their manufacturing. This diagram is commonly used. There are sort of three different scopes that categorize carbon dioxide emissions from the healthcare system. So scope 1, those are emissions under direct control of the actual healthcare facility. Scope 2 are emissions derived from electricity that are purchased by the facility. And then scope 3 comprises all these other indirect emissions. Here's another cool graphic. It's from a 2016 study that shows environmental health impacts of US healthcare facilities, US healthcare activities disaggregated by expenditure categories. So you have the impact category on the left vertical axis, and then the different colors show expenditure categories along the horizontal axis. And then sector totals on the right vertical axis. HH stands for human health. So the impact would be like human health non-cancer versus human health cancer. So for our second objective, I wanted to describe the impacts of climate change on healthcare systems. And so I wanted to answer the question of how can climate change impact the healthcare system? I think we previously discussed health risks of climate change during some of the other talks. Here we just wanted to focus specifically on the system. So climate change intensified extreme weather events hamper access to quality of care for patients and providers alike and can result in major financial losses to healthcare systems. I think this article from a recent health affairs special issue in climate change provides a helpful framework for this topic. It was first authored by an emergency physician at Harvard named Renee Solis, who does a lot of work on climate change and health policy. Basically, it outlines threats to healthcare access, cost, and quality due to climate change. So with regard to healthcare access, key climate change impacts include the intensification of extreme events leading to healthcare system disruption, including hospital evacuations, facility damage and closures, transportation disruptions, power outages, and the displacement of health professionals. This impairs healthcare access, worsens patient outcomes, and results in instability to the workforce. Examples include Hurricane Maria, during which time a third of households had disruptions to healthcare services. Additionally, studies have shown a higher mortality for patients with lung cancer after hurricane disruptions. And another example, during the California 2017 wildfires, 200 Kaiser Permanente employees were displaced. There are also implications for cost to the healthcare system. Altered disease burdens and healthcare delivery disruptions can result in huge costs to the system. For example, climate attributable cases of West Nile virus are projected to cost the United States healthcare system $1.1 billion by 2050. Another example is the cost to hospitals of extreme weather events such as Hurricane Sandy, which resulted in $1.4 billion in losses to NYU's medical center. Lastly, climate change can impact the quality of the healthcare system by increasing hospital crowding, supply chain disruptions, and population displacement. Examples include decreases in quality of care that have been associated with ED overcrowding, and there can be complications with regard to accessing electronic medical records for displaced patients, which can also decrease the quality of care. For my last objective, I wanted to talk about mitigation and adaptation strategies within the healthcare sector. I'm just now realizing that I haven't defined those two words. Adaptation and mitigation are sort of two common keywords in this field. Adaptation refers to essentially helping communities, people, places become more resilient to the adverse effects of climate change. So assuming climate change is happening, which it is, what can we do to help communities bounce back faster? What can we do to protect them? Mitigation, on the other hand, refers to the amount of greenhouse gases we're emitting. And so a mitigation strategy would be, transforming an industry to make the amount of warming less over time. From a health systems perspective, you can think of both adaptation and mitigation measures as categorized by healthcare delivery, payers of healthcare, and public health infrastructure. So public health infrastructure includes public health interventions such as conducting needs assessment, vulnerability assessments, identifying and evaluating adaptation strategies like early warning systems, implementing national climate preparedness plans, and conducting like public health surveillance of climate-related health risks. And I won't go into too much detail since I think some other folks will be covering this in other lectures. There's also a role of payers of healthcare to address the climate risks of health, but there's a lot of room for improvement in this area. And health insurance companies are among those least likely to disclose climate risks in the insurance industry. Examples of interventions include payers such as Medicare and Medicaid, widening the criteria for which vulnerable patients can receive coverage of home cooling devices like air conditioners or subsidized electricity. Payers could also incentivize lower carbon use in healthcare, for instance, reducing coverage for drugs that have high warming potential, or even potentially incentivizing virtual over in-person clinic appointments. Though a lot of these interventions come with the caveat that they have their own set of risks with regard to the quality of care you're providing. And then there's healthcare delivery. Examples within healthcare delivery include national investments in the healthcare system decarbonization, such as building low carbon or net zero emission buildings, investing in resilient healthcare infrastructure and supply chains, promoting interoperable information, so like electronic medical record data sharing, and then building a climate-ready workforce. On a more individual local level, what can health professionals do regarding climate change and health? I feel like lots of physicians will ask this question, they'll get all these talks on climate change and health, and then they're like, what can I do about this? I think another way to look at it is to think about what health professionals versus specialty organizations versus hospitals versus medical educators, what can these folks do? And so with regard to mitigation, there are a number of organizations that are involved with assisting healthcare systems and hospitals in their efforts to decrease their carbon footprints. So this image, it's from an organization called Healthcare Without Harm, which some of you may have heard of. They do a lot of different things, but one of their areas includes providing resources on how health systems can green their operations and workflows by addressing energy consumption, food services, operating room procedures, transportation options, and a variety of other areas. Healthcare Without Harm works closely with an organization called Practice Green Health. And this is a healthcare membership organization that provides professional consulting services and technical support on sustainability solutions to healthcare systems and hospitals. They reportedly service more than 1 in 3 hospitals in the United States. And this picture shows a list of some of the services that they provide. And this topic of reducing greenhouse gas emissions from hospitals, it's becoming increasingly popular, and we're seeing more articles about this published in more clinically oriented journals. So this article, it's a screenshot that's gained some traction within emergency medicine. It's essentially a primer on how to build a climate smart emergency department. So you can also implement some of this at a departmental level. And then healthcare professionals can, of course, engage in climate change and health related research. That's my personal area of interest. This was a relatively small study that I did with some folks a few years ago. We looked at how pre-hospital data can facilitate the detection of acute heat illness. in India. But there's so many research questions that need to be answered, particularly in the Central Valley, whether it's quantifying climate change related disease burden or identifying vulnerable populations or evaluating adaptation and mitigation interventions. And there's also opportunities for healthcare professionals to get involved with climate change education and building a climate ready workforce. So public health and professional students, they're becoming increasingly interested in the topic. Basically, it's students that have been driving the implementation of climate and health education and training in the United States. There was a study at Columbia that surveyed members of this group called the Global Consortium on Climate and Health Education. And they surveyed 59 schools. 80% of those schools reported that student interest was a factor in establishing or developing curricula in climate and health. Unfortunately, while this topic has gained a lot of traction in schools of public health, it's actually received relatively little attention in medical schools. In that same study, 71% of the 59 respondents reported that they encountered challenges such as lack of staff time, resources or funding, competing priorities, or lack of space in the core curriculum. And this actually may be subject to change, given the amount of students who are interested. There's some momentum after a recent resolution that the AMA put out to promote the teaching of climate and health in undergraduate, graduate, and continuing medical education. And there are currently 2 climate change and emergency medicine fellowships that you can do after residency. I believe there's some more in other departments that are currently being launched. This paper here was written by the Harvard and Colorado folks. They're actually really cool. They partner with the National Institute of Environmental Health Sciences and with the CDC's Climate and Health Program. And one program is more policy focused and the other is more research based. And then the last thing is healthcare professionals and their medical societies can make a pretty meaningful impact by getting involved with policy, given the substantial political power of medical lobbying organizations. And one of the best examples of this is the Medical Society Consortium on Climate and Health. This is an organization that brings together, at the time I made this slide, 31 professional medical societies, but I think they've actually increased since then, representing over 60% of US physicians. And since 2017, they've conducted hundreds of presentations and media activities pertaining to climate and health. They've published 94 research publications and engaged in hundreds of policy activities at local, state, national, global levels. National and global levels, I'm sorry. They have this legislative tracker. The screenshot I have here is a bit out of date, but it provides a comprehensive overview of all the bills related to health and climate change, making their way through Congress right now, and they update it on a weekly basis. Within my own field, emergency medicine, there's plenty more we can do. Some colleagues and I actually submitted a resolution that was approved by the American College of Emergency Physicians to officially join this consortium. So that was a small win for us, but you can also join this organization as an individual participant as well. And so to conclude, the healthcare sector is a major contributor of greenhouse gas emissions globally. Climate change has multiple adverse impacts on the healthcare system with regard to cost, access, and quality. At a systems level, effective adaptation and mitigation strategies can be effectively implemented within public health infrastructure by healthcare payers and during healthcare delivery. And healthcare professional educators and professional societies can intervene through mitigation actions, research, and educational and policy initiatives. That's all I have for you.
That's fantastic. Wow, thank you, Nikki, and congratulations on so many of the publications and victories that you've already accomplished in your very brief career. And so, I just feel very fortunate that you selected our emergency medicine program and that you're continuing to do this work during your residency. I think that's really fantastic. I just want to, echo what you said, is that this is a really important issue, especially for the younger generations of healthcare providers. and really it should be a vital issue for all of us for the reasons that you mentioned. I think, we're still trying to figure out what else we can do locally, but this really just feels like a blueprint of the directions that we can potentially move in. So I really look forward to, continuing this conversation, and hopefully we've inspired people on this call to get involved, reach out to us and definitely help us if you're interested in doing some of this work, because it is going to require all hands on deck. I like to very flippantly say that, COVID is just the starter pandemic, and that the many disruptions to healthcare that climate change promises to bring are going to feel like many different pandemics stacked on top of each other. Again, I don't mean to sound hyperbolic. I hope that I'm wrong, but everything that I'm reading indicates that that's exactly how we should be looking at the health impacts of climate change, especially in the vulnerable areas of society. And I feel like the Central Valley is, arguably the most vulnerable area of California. So I'm especially worried about, just a vast number of, populations that don't have enough healthcare access going into a major disaster. And then something like, the series of climate crises that may be coming along in the next few years to decades really promises to cause a lot of different strain and stress on the healthcare system and all these populations. So I think we do need to start moving in this direction and start planning to educate ourselves and then also to help protect some of the more vulnerable populations, not only from the direct impacts of climate change, but some of the indirect impacts that you mentioned because of the ways that the healthcare sector may be affected by various different, climate-related emergencies and disasters that come along. I'm just going to put in a book recommendation. It's actually just a very breezy book. It's not academic at all. It's just written by kind of like a news commentator, but it seems like it just has some really good practicable advice for anyone to just read and act on at the individual level. I think this is going to require just a lot more conversations. A lot of hard conversations, frankly. This is not something that's easy to talk about. It's not really a narrative that kind of bends to, I think, our archetypes of illness or even disaster, and yet it promises to cause the kinds of massive disruptions that COVID has brought to us. So I think we just need to turn around and look at all the lessons that we learned from COVID about how to be resilient, how to really reinforce the healthcare sector, and then how to protect the most vulnerable populations, because I think all of those are going to be very germane to preparation for climate change. Any other questions or comments? And like I said, I'm serious. We do need help, and we'd love to hear from you. So shoot me an email or let me know how we can reach out to you, because again, we'd like to build a clinical collaborative around climate change. And for obvious reasons, I hope it's obvious that Nikki is going to be one of the leaders in this space. And there's many more residents and other professionals that have reached out. So we're really excited that we're going to be able to put together a network that will help solve some of these issues and really help us plan forward. So thank you, Nikki, for this really great presentation.
Thanks for having me.
Oh, go ahead. Yeah.
Can you hear me?
Yes.
Hi, I'm a pediatrician. I work at the Fresno American Indian Health Project, and I wanted some clarification. Hi. So I wanted some clarification on the lead screening testing. So you mentioned that the in-office lead screening is not as good, but I wanted your take on this. So I'm ordering the labs on patients, but they never get those done. So what is your thought? I mean, pediatric patients, as you know, sometimes it's the annual physicals that they come for, and then they get lost to follow up. But I was thinking that there might be some value to doing like an in-office screening lead test, so we can at least get the bad numbers and then chase those aggressively versus just
Oh yeah,
ordering.
no, sorry, I might have misspoken. I said that the commercial, like over-the-counter lead tests, those are the ones that are unreliable. The ones that you've got in your
Okay,
office are probably fine to use. So yeah,
okay,
screening tests. And you know, obviously you should put that together with the history and other risk factors. But yeah, if you're
yes,
office testing and that, you know, it's CLIA approved and it's FDA approved, then it should be fine to use. The things that I'm talking about are like things that you can literally buy at Home Depot. And they basically come with a Q-tip that you're supposed to like swab your paint or swab,
oh yeah,
and then you
rubbish.
basically stick it into a packet, and it's really unreliable. So that's what we want to move away from, and whatever you're doing in your office is probably fine for screening. You may have to do a,
Okay,
especially if it comes back higher, just to get, you know, for example, if you're doing a capillary stick, you may have to do like
yes.
a blood draw if it comes back high, but that's fine. It's a good screening tool, and I know that that's the most convenient thing to do in your office, so you can just continue to do that.
Thank you, appreciate it. Thank you.
Sure, no problem. And I can link to that webinar, that CDPH webinar. They said that they're going to post it soon. So whenever they post that, I'll link that to one of our future transcripts so that you can go back and watch it. It was really well done. You know, there was a panel of 3 different toxicologists that were talking about exactly those kinds of questions. So hopefully that will be valuable to you. It's like a 1-hour lecture that we did a couple of days ago, and it was recorded. And so as soon as they archive it and post it, then I'll be able to share it with the rest of the group.
This is what the lead one? On
Yeah.
lead?
Yeah. It was the CDPH lead prevention branch.
Okay, thank you. Thank you.
Sure, no problem. Thank you. All right. Any other questions about the many different topics that that we covered today? Okay, well, let's keep the conversation going. I hopefully you know how to reach us if you have any other questions, and we will definitely loop back with more updates probably as early as next week. Thanks, everyone, and happy Halloween. Stay safe this weekend. Take care.